is Dr. Aida Nguyen, geriatrician at the Department of Geriatric Medicine at JAPSOM. Thank you for joining us for this ECHO, Long-Term Services and Supports COVID Preparation Series. A special thanks to our collaborators at Hawaii Emergency Management Agency, Healthcare Agency of Hawaii, Hawaii Directors of Nursing, Hawaii Medical Directors Association, and Mountain Pacific Quality Health. Next slide, please. We usually have a brief presentation to open up for time of questions and then open it up for a time of questions and discussion up to about 3 p.m. And we ask you to use the chat box to submit and queue up your questions. Next slide. This is the schedule of upcoming talks. Today, we're going to be talking about getting through your first case. This coming Wednesday, we have a session on COVID conversations with Dr. Takeshi Uemura and Eric Chin. Dr. Chin is actually doing those COVID conversations in Seattle right now. On Friday, talking about COVID units and cohorting, and then on next Monday about care homes, COVID in the care homes. Next slide. Okay, so we will be offering CMEs, and nurses can use CE for this purpose as well. And we can offer certificates of attendance to all participants who complete an evaluation form. And if you haven't registered, we actually encourage you to do so after this webinar. And evaluations can be found on our website under the evaluations tab, or just by following the link in the chat box, which we will have. This time, we ask you to enter the names of all of the attendees in the chat box for attendance purposes. And for those of you calling in on the phone, please unmute yourself and tell us your name. And we can write this down, or maybe afterwards we put your name down.
Naomi Marita.
You have to ask people to mute their phones, though, if you can, if you're not speaking. Okay, finally, some announcements. Next slide. So just want to let you know, we actually got some feedback on the nursing home testing and management flow sheet from 2 weeks ago. And I wanted to clarify that these are not official flow sheets, but these are rather just templates that you can use and modify that fit your particular nursing home. So I didn't want you to feel like you were wedded to these. They're just guidelines. And then this is the reminder that folks from UH Pacific Basin Telehealth Resource Center, they want to provide assistance to help your facilities become telehealth ready. And so please feel free to join them this Thursday, April the 30th from 1 to 2 p.m. And this is the link here. So just so you know. Okay, so we're moving on for today's topic, getting through the first case. Today we have a very special guest speaker, Dr. Swati Gaur. She is board certified in internal medicine, geriatrics, and hospice and palliative medicine. She's a medical director of New Horizons Nursing Facility with the Northeast Georgia Health. She has an MBA as well from Georgia Institute of Technology, and is CEO of Advances in Technology, a technology innovation company. She actively serves on AMDA in many capabilities, including that she is the current chair of the Infection Advisory Committee. She is also a member of the State Antimicrobial Stewardship Committee with the Georgia Department of Public Health. She recently gave a presentation at the Society for Post-Acute and Long-Term Care Medicine at the national meeting in March on COVID. We are very fortunate that she's willing to be available to us for us to glean her experience on the front lines and be able to ask her questions. So today's session is going to be a little different. We're actually not going to have a PowerPoint presentation, but instead we will have Heather Haynes and Nicole Apoliana from Maui share their situation and experience from their first positive cases. And Caitlin Cook can join in as well about her perspective from Department of Health. And then we can have Dr. Swati Gaur share her wisdom. Okay, so I'm really happy to see Heather joining us for a little while. And I'm gonna actually, let's see, have you say hello? And actually, if we could also have Dr. Swati say hello as well, just so everybody knows who you are.
Hey, how are you?
Okay, great. All right, and then Dr. Haynes.
Hi, yeah, I'm here. I'm Allie.
Okay, great. And I think Nicole, are you around? You want to say hello? Oh, yep, you're there.
Hi.
You can say hello as
Hi.
well. Great.
Thank you.
Okay, great. So I'd like to open the forum, and if either of you, Heather or Nicole, want to start off with sharing what the situation was like there in Maui.
Nicole, do you want to go first? Or you want me to go first?
Either one.
Okay.
Go ahead. I went first last time. You go first.
Okay. All right. I'll go. Well, we'll go first in the chronological order of our events that occurred, I think. So we were notified of a healthcare worker at our facility. We became aware that some therapists had come up to our facility who had worked at Maui Memorial. They hadn't been down there for over a week, but this was after Maui Memorial had started having those positive COVID cases that were internal, with internal transmission. So they came on Monday through Wednesday. We actually sent them to the drive-up testing, mass testing that was done on Maui on Thursday. And we got a positive result on one of those therapy staff members on Saturday evening. So that was the 11th. A healthcare worker who had been at our facility from Monday through Wednesday was wearing a cloth mask the whole time she was here. This was before we all went to surgical masks on everybody. And we were able to trace her exposures immediately because our therapy department was doing really good productivity documentation. So on Saturday night, we identified 15 patients who had exposure to this healthcare worker. And the patients were unmasked. The healthcare worker was wearing a cloth mask, and also 8 therapy staff and 2 other staff on the floor who worked closely with this person. The therapy staff had all been in a break room type meeting for an hour together with no one wearing masks. And then other shorter period of times, shorter intervals of time in a small office area without masks on. So they all had high risk exposures. The 15 patients were immediately cohorted, but not sent all to a separate unit, and put on enhanced droplet precautions and tested. Their initial tests all came back negative. They were maintained on the enhanced droplet precautions for 14 days, tested again day 7 after their last exposure to the healthcare worker, which was day 9. No, day 7 after their first test, day 9 after their last exposure. Those tests were negative too. And then they were released from isolation on day 14. None of them had had any symptoms. The healthcare workers were all tested and quarantined at home for 14 days. They tested negative and were asymptomatic. Well, one was symptomatic on like the 14th day with a sore throat. We tested her again and that was negative. So she came back to work, I think on day 16 or 17. And the remainder came back to work on day 14. And that's it, hopefully, fingers crossed.
Okay, I don't know, should I go into Halemakua now, or do we want? Yeah, okay. So we, starting March 23rd, we were cohorting all of the new admissions into one separate unit. So everybody was going to one unit with employees only working in that unit too. And then on the 9th, when we became aware of what was going on at the hospital, we tested there was 31 patients there on this one unit, tested all of them, everybody came back negative. On the 11th, we were notified that 6 of those 31 had been potentially exposed to a positive healthcare worker at the hospital. So they were all put in isolation, and everybody was asymptomatic at that point. And then of those, our administrator sort of went and dug a little deeper on her own and was able to sort of figure out that 2 of those 6 were probably the highest risk, just based on what floors they were on, kind of based on, you know, stories. I don't even know exactly what she based it on, but she retested 2 of those 6. So that's one of the 2 came back positive. So that was our positive case. And that came back all my notes aren't here, sorry, but I believe it came back either on the 14th or 15th. So at that point, we had 6 that were isolated, that were potential exposures, and then we had the other 25 that were in just cohorted together on one unit. on the 15th, which would have been about 4 days, day 4 from everybody being removed from the last exposure, we retested all 30 patients who were cohorted and 74 employees. At that point, the employees were felt to be low risk exposure based on everybody had been wearing universal masks and everything. So they continued to work and monitor their symptoms, and everybody was fine. And all of those tests came back negative. The positive patient did end up getting symptomatic with fevers. To my knowledge, he's doing better. And it's been a couple days, but he was definitely getting better. So he's doing okay. Everybody else remained asymptomatic. And then on Saturday was the 25th, was day 14. They were all basically released from isolation at that point.
Okay.
Heather, is your symptomatic patient still on isolation?
I don't know. I just texted my DON to ask her what's happening as of today. I actually don't know that. We had talked about keeping him on because he was still symptomatic up until, I want to say it was about Thursday. And then he was kind of on round the clock Tylenol. So we had to stop the Tylenol to see what he was really doing. But he felt much better. And so it seemed like he was beyond, but I don't know as of today what's going on. Sorry.
Okay. Any initial thoughts, Dr. Gore?
Yeah, that's, I think both of those stories have such such a moral to the story, right? These days, what is happening is, at least on the mainland, what I have heard is if it's in your community, it's going to come into your nursing home, and you just need to do everything that you can. So your first line of defense is to protect it from coming into your nursing home. The second line is to protect the spread. So I think one of the, what Nicole had talked about, that healthcare worker, I will tell you our story in our long-term care facility. We currently have, our first case was diagnosed on 3/31. That was our first case. And what we had been doing is, prior to that, we were utilizing the AMDA tool, and it's a shameless plug for that tool, screening tool. Do it, we are doing it every shift, which is, we have 12-hour shifts. So the staff goes around, does vital signs, especially temperatures and pulse ox, as well as asks all the common and uncommon symptoms that is in the screening tool. And they administer that tool to all patients, and we actively try to look for cases, and which I think is a really good idea, because that kind of prevents the spread. That is prevention of the spread piece of it. One of the important things in your vignette, Nicole, is the fact that the staff had exposure to each other. They were sitting together and not wearing masks. And this is something that we found out. Our moral of the story was that we needed to wear masks. So I will tell you, our case was on 3/31, and that was an interesting case, and we'll talk more about it. However, we screened everyone. All residents were then tested after that. We did massive testing. 97 residents were tested after that. And we found that there were 8 people who were positive out of those. And we moved them into a COVID unit. That's because we had prepared. We started preparing late February, early March. And on 31st of March, when we had our first case, on 4/2, all our residents were tested extensively. We had 7 asymptomatic positive cases. And because we had prepped for it, we were able to move those asymptomatic positive cases only, not PUIs, just asymptomatic positive cases, into our COVID unit that we had created. What we also did is we actually tested our staff. We tested about 119 staff members, out of which 15 staff members tested positive. and they were all different domains. So they were physical therapists, activities, MDS coordinators, CNAs, and nurses and nurse managers. So what our moral of the story was that we needed to really pay attention to masking when we were interacting with each other. And we had put universal masking for, while taking care of the patients early, like on 310 with the staff. So since 310, they were all masking, and they were surgical masks that they were using. We realized after our story that that basically what we needed to do is a better way of masking and hand hygiene, because you can never tell who is asymptomatic or pre-symptomatic patient. And so what we did is, in addition to the masks, we also got these face shields for our staff, because number one, it protects the staff, because we are assuming that the transmission happened between the staff member who would have brought the disease in to the unit, because patients, we don't keep it in the nursing home, gave it to the patient, then it was patient to staff, staff to staff, and staff to patient transmission. So we said, how can we minimize that? And that's when we said, we are going to wear a mask, and also we're going to wear a shield, and that is to protect the staff, patient to staff transmission, as well as keep the staff from really manipulating this mask, because no matter how much we have done so many interventions to make sure that the staff is not touching their masks like this, or really doing good mask hygiene, but that is almost impossible. I figured out. I have been sitting in meetings and talking about this: you don't touch the front of the mask, while staff is like trying to manipulate the front of their masks, and I'm freaking out in a big way. I'm like, you guys are all doing it while I'm telling you that you shouldn't do it. So that, I think, helps. That shield helps the staff not reach under, because it becomes uncomfortable for them. As far as hand hygiene is concerned, what we have done is we have instituted a buddy system for proper donning and doffing of PPE. We have done secret shopper program where, somebody, either your infection preventionist, or we have even gotten secretaries to go in and do a secret shopper program where they are monitoring the opportunities for error is the denominator, and the numerator is the actual error in donning and doffing of their PPE, as well as washing their hands. Hand washing is the biggest thing that is going to protect your staff and patients. So we have done that, and we finally actually 2 weeks ago, or rather week ago, actually went to patients' rooms and said, we need your help. Don't let the staff approach you if their mask is not above their nose and underneath their chin. So we put posters in patients' rooms now, basically getting them, empowering them, and making sure that they are participating in this good hand hygiene program. And there are only 3 points. One is, don't let them approach you with a poor mask hygiene. Don't let them touch the curtains or touch anything before they touch you, and show that they are actually washing their hands when they're approaching you. So those are the posters that have gone up, and our residents are like all gung-ho about helping our staff out with their input. So that is one of the things that we have done. The other thing that we did when we found out that we had so much of staff transmission that happened is we have made sure that the staff is not going to take their mask off while they are in the building. So they get into the building, they get their screening, they get their temperature checked, they get asked about all the respiratory questions, as well as the uncommon symptoms of COVID. Because a lot of, in our part of the neck of the woods, a lot of times the staff is having nausea, and also the patients, nausea and diarrhea is their number 1, number 2, number 3 symptom. That's the only symptom they are having. There is no respiratory symptoms whatsoever in some staff. And I'm I'm one of them. I contracted COVID from the nurse manager who I was working with, and I was right at that day 10 and figured out that, I woke up with nausea one night and found out that I was positive for COVID. So I'm recovering now, but it was really nausea and diarrhea. So make sure that that screening tool is there for the staff when they're entering the building. Also, no, I saw this, somebody had put in the chat box, loss of sense of smell or taste. No, I was so nauseated, and I honestly don't like the bananas. I love the Hawaiian bananas, but I don't like the bananas here, and I could still smell that banana, and it made me so sick. So no, I wish I had lost my sense of smell then. But yeah, so that is some of the symptoms that we are seeing here in the staff. I'm sure that all the facilities have completely restricted the visitors. Is that the case? Yeah. Okay. Good. So that is an important piece, that complete restriction of visitors. We were allowing laundry service, families to do laundry, because we said that that is a good way to kind of families to be involved. We have completely shut it down. The other way, how can it enter your building? Dialysis patients. We have cohorted the dialysis patients, and we also put in the guidance, the AMDA guidance, that basically put your dialysis patients in one single room. If you can afford it, you need to put them in a single room. Our dialysis patients are actually going with mask to dialysis. They are masked. Their staff is also putting a hair cap. I don't know the value of that. There is no evidence one way or the other, but the staff has decided to put hospital gown over their regular clothes, as well as when they come back, they do a good hand, they take the gown off, throw it in the laundry, take the mask off of the patient, throw it, and then they do good hand washing of hands, and then all exposed areas. That's what the staff is doing, because a lot of index cases in the country have been dialysis patients, because they have this constant exposure. How else can we get COVID into the building is just look at the outside appointments that the patients might be having. What we have done is we have called, our secretaries have called, for the next 2 or 3 months. They have pushed out all the non-urgent appointments. That is important to do. Admissions, we have been cohorting our admissions, and it is recommended that you cohort your admissions. And if you can put them in a single room, in a single wing, that is lovely. But a lot of times we don't have that luxury. So if you cannot put a single patient in a single room, what you want to do is cohort them by days. So like 13th day should be cohorted with a 12th or 13th day, rather than being cohorted with a second day. So that kind of cohorting is important. Those are the ways that the patients can bring in COVID. The most important people who are going to bring in COVID, like you have, I think you guys have proven to yourself, and we have proven to ourselves as staff members. And there is so much of asymptomatic and pre-symptomatic disease that is rampant in our buildings, that we really have to assume that every patient could have it and every staff member could have it. And that's why we went and we said, we're going to go all PPE, so the mask and the shield. That's the day that we instituted a mask and a shield. And your staff should not be taking breaks together. It doesn't work. If we are stopping all communal activities for our patients, we need to stop all communal activities for staff. So our staff is sitting separately. Now we have this huge dining areas that are available. They're sitting one person, one table, and eating their lunch, and not having any communal activities. So that is important to also remember.
Yeah, I was wondering if maybe, I think Heather and Nicole had some questions about testing, like sort of more universal testing of staff. You want to go ahead and ask?
I guess, so we don't have the capability right now to do a fast turnaround or to test, like if I wanted to test my whole facility, it would be similar numbers to your facility. And I would have to negotiate pretty strongly to get enough test kits even. And then the turnaround time could be up to 5 days.
Wow.
For those tests, 5 to 7 days, which kind of, sort of negates their value to me. So I'm just wondering what the testing availability is in your place. If we had a de novo case of COVID in our facility, I would definitely advocate as hard as I could to test all the patients and all the staff. But CMS also recommends at that point that you should go to N95 mask and full precautions for every single patient in the facility, which is a huge PPE use. But
It is.
did you do that in your facility?
No, we can't afford it. We don't have it. We just don't have enough PPEs, the gowns. We don't have the gowns. What we have done is we have risk stratified our isolation. So in our COVID unit that we have now, we have, so let's talk about PPE, then we'll come to testing. In our COVID unit, my goal is to protect the staff. You can't give, hopefully you can't give more COVID to one patient who already has COVID. So my goal is to protect the staff in that unit. So in that unit, the staff is wearing N95 masks. And we have, basically what we have done is we have limited supply of N95 masks. So what we have done is really talk to the staff, given them 3 or 4 N95 masks, and ask them to rotate it. So it's like day 1, day 2, day 3. So staff writes their name outside of the N95 mask, and they write day 1, and then day 3, and day 6 on that mask. And then the second mask is going to have day 2 and day 4, and then, or day 5, and then same thing with the third mask. So they will have these different masks. And what we have done is we have talked about, conserving your mask in a shoebox. I don't know if you guys know about that, but basically you take your N95 mask, you look inside a cardboard, hopefully a cardboard shoebox, because cardboard allows it to dry better. So you kind of look into a clean cardboard shoebox while wearing a mask, and you take the back strap off, and then you take both the straps off, and now your shoebox is wearing the mask, and you just take your head away. So it's not touching the outside is not touching any surface, the inside is not touching any surface, and then you leave it open to dry, and then you wear the day 2. So that's how we are wearing the N95 masks. Our most important people, and what we are doing actually in our COVID units is we are wearing the same gown if the patients don't have any other infection tags. So for example, we're not wanting to wear the ESBL gown to another patient or a MRSA gown to another patient, but if they are COVID infection tags, staff can literally wear the same gown through multiple patients. Not ideal, but we are in a critical supply of the gowns. So the most critical part where you have to use and throw your gowns is your PUIs, where they screened positive and you're observing them. That is the most critical place where the staff needs to wear full PPE. That's the highest risk category. And then there are people, for example, new admissions from the hospital who have not had any symptoms. When the admission comes from the hospital, so the way our hospital admission works is we have 2 independent people literally taking that screening checklist that AMDA had, and they reviewed the chart of the patient while they were considering admission. And they would go over the chart of the patient and say, in this hospital stay, do they have any of these common or uncommon signs or symptoms of COVID? If they did, we requested the hospital to do a COVID test. If they didn't, we brought the patient in. We brought them in, our staff wore full PPE as if they have COVID, assessed them, and then put them in that single room. If they didn't have symptoms in 72 hours, we brought them down to a lower category of PPE stratification. And essentially, we are left with either fabric gowns or these surgical gowns that can be reused maybe through the day, or even hospital gowns. And now the staff is at hospital gown level. So people who are not having any symptoms whatsoever and are only being observed, like our dialysis patients or our new admissions that have been with us for a little while and have no symptoms, they are the lower risk category where the staff is going in and wearing the hospital gowns. When they're wearing hospital gowns, we are asking them to not wear full sleeves and wear short sleeves and clean their hands all the way up to the elbows if they are using the hospital gowns, because they are short-sleeved gowns. So that's our story of PPE. Everyone is wearing a shield, every single person, whether you're wearing a surgical mask versus N95, it doesn't matter, you've got to wear a shield. Protect your eyes. Don't give the shield to people who are shower team, because it fogs it up and then they tend to try to go reach inside of that shield. That's not a good idea. We have given goggles to them. The shower team has goggles so that they don't break that barrier of protection and, get in the place where they need to touch their masks. So that's very important. We have also started handing fabric masks to our residents. That is something that we have done in the last 14 days. All our residents who can potentially wear fabric masks have been wearing fabric masks during the day. At night, we take them off because we don't want them asphyxiated. But every morning, the CNAs are going and giving fabric masks to our patients to minimize that spread again. To keep the N95 masks and to protect their N95 masks, we have advised the staff, if they can tolerate it, they can use a fabric mask and then throw it in the laundry. That extends the life of the N95 mask. I know that staff finds it very difficult to breathe through both the barriers. Testing, yes, so we have testing. We were fortunate that we had extensive testing kits available. We don't have them now. So I have 2 facilities, and we are not really repeating the story of our first facility. And here is why. We tested our first facility and we took all our patients that we had asymptomatic positive to a COVID unit. What we noticed is 4 days later, somebody came back symptomatic on the unit that had the bigger cluster. And we tested them, they were negative. We tested them again, they were negative again, because I'm like, this is influenza-like illness for all practical purposes. If you have COVID in your building or in your community, you gotta be careful. It is COVID unless you prove it otherwise. We tested him 3 times. His 3rd test came back positive. So you gotta be careful about testing. First of all, they're 25 to 30% false negative. And so clinical suspicion is a big deal. You got to have your clinical suspicion that if the test is telling you something that your mind is saying that, clinically this is COVID, trust yourself. What we figured out is, even if you do extensive testing, in 4 days, you're going to be in the same situation that you were in when you did the point prevalence, prior to doing point prevalence. So essentially, you have to really, whether you have testing or you have no testing, you have to assume that anybody and everybody could have COVID. And that's where you need to focus, is the measures that you put in place need to be clean, good hand washing, good infection prevention and control practices. One of the things that I would say is that we did realize that, we had not talked to our EVS professionals, and make sure that when you are getting ready, that's an area that kind of gets overlooked. Get your EVS professionals within your environmental services, cleaning people, into the loop, because here is, I've always talked about COVID like wet paint. It is, and that's the concept that people tend to understand. that if you take the same rag and you're like going around on two different sides of the curtain, you may have spread it, like wet paint. So what we have asked our EVS people to do is clean one side of the room, deglove, throw away your rag, deglove, wash your hands, reglove, use a fresh equipment, and then clean the other side of the room. You will have to treat the two sides of the room like they are two different rooms for all practical purposes. This goes for the physicians, this goes for the nurses, this goes for the EVS people, it goes for everyone. That is extremely important. The other thing that is going to be very important is it seems like COVID is on the island. So you got to anticipate that it's going to come into your building, and there's some evidence already. And so the second line of defense is prepare really well. I think there's merit to taking all your COVID patients and putting them in a separate unit. That is because if you say that the staff may have, we are all human beings. If we have 10% chance of error in hand washing and good infection control practices, then you want to minimize that the number of times that the error could happen. So that, I think, it decreases the burden of COVID in your regular units, and it decreases that total chance of errors, or total number of errors that could be happening. So it's very beneficial for that reason. It conserves PPE. And then it also really makes you focus more on those COVID patients, because they could get very sick very quickly. So I think those readiness efforts need to be had, because it's going to happen, and it's going to happen at 2:00 in the morning. So also talk to the EVS professionals that you really need to have an on-call schedule. That is something that we did just in the nick of time. And yes, we were moving all our patients until, 5:00 in the morning, and we had on-call EVS people. So make sure that you have that available.
Oh, wow. Okay. So that was like a water hose. So I think we need to recap a little bit, maybe. So I guess there was this question about, and you addressed part of it, right? Testing everyone, and what's the utility of that? And what I heard was maybe not, and maybe more beneficial is the tiered stratification of the cohorting, and to sort of conserve the mass, because we ideally, but we don't have enough total PPE for everyone, and I'm not sure we ever will. So I just wanted to clarify, because so it seems like there's this COVID unit with the max, then there's this new admission unit as tier 2, and then there's that observation after 3 days of those are the 3 levels of PPE stratification, and that should be done the entire facility at all times, even if you don't have the first case in there yet. If it's outside the community.
Yes, I think, if you don't have the first case yet, your cases are going to come from dialysis patients and your new admissions. So that's going to be your area of maximum interest. And then, of course, your staff. It's going to come from your staff. So the staff needs to really pay attention at all times.
Okay. Okay, so we have some other questions. Okay, so there's something about, what is the criteria to discharge from facility? Are patients still contagious when they're discharged to community?
So CDC actually really wants us to do, when people are getting discharged to the community, you can discharge them if they can self-isolate. So essentially, when the hospital is discharging patients to the community, they're not keeping the patients in the hospital, because their assumption is that they can self-isolate. So we had a possible case which was negative, but he was having influenza-like illness, and we had to discharge him prior to his 14 days, after the last symptom were up. And what we did is we discharged him with the CDC guidance on how to self-isolate and self-quarantine, so that you can go on the CDC website and you can make that available to the patient if they are able to self-isolate. If they are not able to self-isolate, that is a negotiation with the family, really, to see if they can do it.
Okay. Oh, here's an interesting one about family bringing in food to the residents. Is that a source of infection?
Yeah, we have, unfortunately, I mean, we have really tried to stop that now. You
Hmm.
know, we are allowing in our COVID unit, the families to bring whatever they want to bring for their residents. And, you know, the value of that is basically we want to make sure that the families are involved in the care of our COVID patients as much as they can without putting themselves at risk. So they are allowed to bring in stuff for their residents.
Right. I suppose the window visits is a similar question, but
Yeah,
no
window
touch.
visits is a great idea. I went to the administrator of my facility and I said, let's get all our windows cleaned. We got our company who cleans our windows to get all the windows cleaned. And when I talked about advanced care planning and possible, you know, treatment in place, we offered that to the patients' families, and we have several families who are actually sitting outside of the window with their picnic chairs, and I'm like, go for it, go for a picnic, you know. So
Yeah. Okay. So there's a few questions about new admissions and cohorting them, and also doing droplet isolation as well, right? So you have to
yes,
do both.
absolutely.
Right.
For 14 days, you gotta try to isolate them for 14 days with droplet precautions.
Right. And we keep those patients separately isolated than those who are COVID positive. Is that correct?
Absolutely,
Don't mix
absolutely.
those two
Just
together.
don't mix those two. Yeah, in a different place. Our COVID unit, if you are contemplating a COVID unit, you gotta realize that it should have an entrance to the outside. So exit to the outside. That's the ideal COVID unit. Your staff doesn't need to come into your main nursing home. That staff needs to just go home straight up and not enter. So, and then cohort your staff into that unit. So that staff should not be working in the rest of the nursing home, hopefully. And cohort the equipment. We had our VP of post-acute care go to another part of the state to get a medicine card because I was like, no, we're just not going to share equipment. So that becomes incredibly important.
Great. Now, I know that there's some folks that want to do maybe, because the staff are the Trojan horse, should we be doing regular testing of staff?
I mean, I can tell you that if you have the tests, I would not say no. My problem is we don't have tests, those kind of tests. So what do we do? So we have to assume that any staff member could bring it in and really drill that good infection control and prevention practices into the staff. Make sure that you have a good visitor. Are you guys doing temperature checks for the staff? Yeah.
Most facilities, yes.
Yeah. I can tell you that my temperature did not go above, I think it touched 99, but that's all. So I would have failed the temperature, I would have passed the screen through the temperature check if somebody had not asked me about the common and uncommon symptoms of COVID. Well, I didn't show up. I didn't show up, but had somebody asked me as a staff member, I would have just passed through that screen process. So make sure that people are aware of the common and uncommon symptoms and can hold themselves behind if they don't feel so great. What we have done instead is we have negotiated with our employee health and basically said, listen, this is a high risk area. We cannot have the staff coming in sick. So we have low thresholds of testing, staff in long-term care. And that is something that we negotiated. So I'm sure that the hospital staff doesn't have the same luxury. We are a part of the health system. And hospital staff doesn't have the luxury, but if we are calling employee health and saying, please test these people, they are getting tested. So have a low threshold of testing the staff. But I don't think it is practical to test the staff frequently. I mean, we tested the staff sent staff to go get tested on Thursday and Friday en masse. And we tested 119 staff. On Saturday, the administrator of our facility was sick and she had COVID. So that's how long it takes for the staff to convert. So you can't keep testing every day, that's my point.
Okay, great. There's an interesting question about Transmission through the feet on the bottom of the shoes. Consider spraying the bottom of the shoes with Lysol when leaving the COVID units, or?
I mean, sure. I mean, you could do that. And this is the study that this is the study that basically showed a study in ICU that showed that there was COVID found on the shoes, under the bed of the patient, on the bed rails, on the windowsills. That's how far it is going and staying. So it's really fomite-based spread that we are also worried about. So that's why EVS becomes so important, and for them not to like spread it all around, because it's everywhere. So yes, it's a great idea to at least not bring your shoes inside the house and leave them outside, and wear the same shoes, you know, for the duration. But sure, spray Lysol, it's not a bad idea.
Okay, about putting more than one N95 mask in the cardboard shoebox, or is it just one per?
One per shoebox.
One per shoebox, yeah.
3 shoe boxes or 4 shoe boxes, and then you write your days, and you just rotate them so that you're wearing the N95 once in every 3 days. So hopefully it gets chance to dry up and get decontaminated.
Yeah, quick question about Lysol. Dwell time is longer than 5 minutes, or we have any idea?
I'm sorry, just
Lysol?
don't drink it, that's all. You know, Lysol is not for drinking. Sorry, that was a bad joke. I don't know.
Yeah.
I have no idea.
Okay. In your facility, I suppose you're paying attention to the psychosocial issues as well. Are you designating staff to become tech support and leveraging technology to reduce patient isolation?
Yes, big time. The day that we instituted visitor restriction, we in our facility instituted visitor restriction prior to CMS coming out. And I can tell you that my administrator had such a hard time saying that, oh, we can't do this. And I'm like, yes, you will have to. And that is the day that they went out. I said, we are not going to institute this unless we have iPads. So we got our activity staff iPads, and there were one iPad per facility. And essentially that iPad is used only for express purpose of FaceTiming their loved ones. So our activity staff who's not playing bingo anymore and doing any communal activities, what we did is we asked them to basically create a schedule book and scheduled appointments with the family. For example, Mrs. So-and-so, we'll call your FaceTime with your family every, Monday, Wednesday, Friday at this time. And that schedule book helps incredibly, because the families know that they will be seeing their loved ones and they're not having this, extreme anxiety. And same with the residents. What else have we done? I've met with our dietitians and our kitchen staff and said, you know what, how can we bring pleasure into people's lives who are isolated? And so we changed up our menus. We are doing ice creams. I'm from Georgia. I hate it. I mean, it's fried chicken. Do whatever people feel happy with. So basically we are using food as a source of joy. We reached out. Yeah, I mean, you do whatever you have to. We reached out to the local community schools, and we asked them to write letters, and essentially gave them an email address for the activity staff. They wrote letters to the activity staff, and those letters were then put in envelopes and handwritten with their handwritten names. And they went to all patients talking about hope and great things to come. So, we are doing a lot of stuff, and also bringing families, via the window, etc.
Okay, great. What about telemedicine? Are all your geriatricians doing telemedicine at this point?
Yes. So one of the things.
No role for going in, right?
What's that?
Is there no role for going in?
No, it's basically, I can tell you that I am just more comfortable in the facility and not be on, behind a camera. because I like to be in the midst of everything, and it makes me crazy. So I had a huge, like Nicole's facility, I had a huge exposure to my nurse manager who tested positive. And so I had to quarantine myself for 14 days, and that was making me crazy. And literally I went to get tested, kept ignoring my symptoms, and just went to get tested to get a negative test so that I can go back to the facility, and it turned back positive, which stinks in a big way. But get telemedicine ready. And I can tell you, you can get telemedicine ready very, very quickly. What we did is we ordered these tripods and iPads, and we got Zoom on it. And but you will have to have a nurse in the facility helping you out. If you're going to multiple facilities, don't do it. That's a really poor idea. I go to multiple facilities. I could have given it to all of those patients and staff. So that's very important. Get telemedicine now. It's a fairly easy setup, and it's gonna pay itself off. So that is going to be important. The most important thing about telemedicine is really you'll have to work around your staff, because you don't want to take the staff away from feeding patients. One of the things that we have done and we have been noticing is patients are not drinking as much fluids as they used to. So we have become extremely cognizant of that. And that's why we are bringing in all kinds of unhealthy drinks or whatever they want to drink. And we're like, drink whatever, just drink. So not alcohol. Alcohol is only used as hand sanitizer. So we may yet get to that, but get telemedicine.
Great. Just a note, thank you, that Lysol dwell time is at least 3 minutes. Somebody did a little research on that for the manufacturer. Okay, any other comments or questions from folks? Caitlin, I don't know if you want to say anything.
Yeah, this is Caitlin from DOH. That was such a phenomenal presentation. I really appreciate all that input. Two things, we've seen the break room thing here too, and other situations I've investigated, not just in long-term care, but every healthcare setting. The vast majority of transmission among healthcare workers has been coworker to coworker. And, I think they go in the break room, they take their mask off, they eat lunch. And this really seems to be the biggest risk for our healthcare workers right now. So we're finding that here as well. Second thing, for whoever's on the call, the universal masking, making sure it's a medical mask and not a cloth face covering. And if you're having issues acquiring appropriate PPE for that, don't be shy about reaching out to HHEMC, the PPE distributors. If you're part of the coalition, or even if you're not, reach out and try to advocate to get the PPE that you need. I think some of those folks are on this call too, but I've heard that they're able to fulfill most or all requests for PPE. So don't save your medical masks and have people wearing cloths now. I do have one question. What is your facility using for return to work criteria for your ill COVID-19 positive healthcare workers?
So you're essentially talking about somebody like me. So basically it's the testing-based criteria that we are using. And CDC really, long-term care is a very high-risk area, and that's why we are using the testing-based criteria. So I will have to go, so it's basically the same, 7 days from your first symptom to 72 hours from your last fever without Tylenol, and absence of symptoms, you can go. Here is what I can tell you. Most of our staff was asymptomatic, who was tested positive. We tested them, especially the nurses, because we were in such a staff crunch. We tested the nurses in 7 days. All of them turned back positive. Every single one of them was positive. We tested several of our staff members this week, again, like 14 days. At 14 days, half of our staff is back now. And some are still kind of those stragglers. As far as patients are concerned, again, testing-based criteria. So we put our patients in COVID unit. Knock on wood, several of our patients still do not have symptoms, and they're eager to come back. So we tested last week 4 of those patients who were completely asymptomatic, and 3 out of them turned back positive. So, but since then, we have had 2 patients that we have assimilated back by having those 2 negatives 14 days after the last symptom is what we are using, just to be overly cautious. And we are bringing them in a single room for 7 more days. Don't ask me why. There is no rhyme or reason. It's called once bitten, twice shy.
Thank you.
So I'm sorry, the healthcare workers are out for 7 days since their beginning symptom and resolution of fever and symptoms improving. And then you're also doing 2 tests 24 hours apart?
For long-term care, we are doing it. So CDC has testing-based strategy and non-testing based strategy, and the hospitals are using non-testing based strategy because they cannot afford, a testing-based strategy. Long-term care, because especially if you're a COVID naive facility, you got to keep it out if you can. And that is so much hangs and balance that a testing-based strategy is a better strategy. So you want to do that. CDC basically says that you can start from, it's the 7 days from symptoms, start of symptoms, 72 hours from fever, and no complete elimination of any respiratory symptoms should qualify you to come back and work, but they still are saying that you have to wear a mask for a total of 14 days. What we are seeing is that, we have proven to ourselves that at 7 days, a lot of our staff was still positive. All of them. So, we're just gonna have to shift to that 14 days.
So you would so for an asymptomatic person who tested positive, you would keep them out for the 14 days and still test at 14 days before you brought them back?
Yes, you can start testing at 10 to 14 days. If you wanted to. We have had 1 staff member who actually tested negative. Their first negative test was at 10 days. You can try 7 days. You can really stratify the staff members and try at 7 days if they were completely asymptomatic. But I would do it in small chunks. I was so thankful that we didn't waste 15 tests. We were just going to stratify it by who we needed, the staff that we were really crunched for, and, they were nurses. So we brought like 5 nurses. They were all positive. But then, at 10 days, one of our MDS coordinator turned negative, and then she went back 24 hours later, tested negative again, and she's back to work. And a lot of our staff is back to work now.
Great. Any other questions? Oh no, it's 3 o'clock. How did that happen? Wow, time flies so fast. So yeah, that was really great. And I see just a couple other comments in here that I think about where to get boxes from Costco, and the technical support. So Dan Saltman is offering help. But actually, I would encourage Dan, if you could also reach out to the UH Pacific Basin guys, because maybe work with them, because they're also working with folks. Maybe in conjunction, that would be a great idea. Yeah, because we're trying to get everybody to get on telemedicine as fast as can. All right, so let me just give you the.
It's Nicole. We talked at the talk last week about a long-term care inpatient 21-day isolation for a positive COVID.
Yeah. So we were talking with Caitlin Cook and the DOH guys, and wanting to be super conservative about that. And so we sort of, for the residents, not for the healthcare workers, but for the residents, we thought we might extend it to 21 days, just because, the viral shedding period, and these guys are extra vulnerable. Does that sound reasonable to you?
Very reasonable. That just basically validates what I'm doing, and I'm like, I just pulled it out of thin air. But thank you for validating that. Yes.
Yeah, and we had said 21 days since symptom onset, and I think you just said 14 days after last symptom, or did I miss?
About 21 days, yeah.
Yeah.
14 days from the last symptom. We, even because our testing has been so erratic, that we have had to really make a lot of clinical decisions. And now what we are saying is, because we cannot afford to spread the disease, if we have a PUI that tested negative, that has symptoms, of increased cough, also I wanted to talk to you briefly about our first case. It was such a crazy case. That person was actually, the only symptom they had was headache and fever, which was low-grade fever. And they had a 20,000 white count and suprapubic tenderness and an indwelling Foley. And when we changed the Foley, they had pus coming out of the penis. So, and they responded to Rocephin. So if we didn't have a proper screening tool and a separate screening process, we would have completely missed it. So be very aware of these two infections going on. We have had multiple people who have had superimposed pneumonias and UTIs in addition to COVID. So don't, just because somebody has a UTI or worsening of CHF or they cough like this all the time, if the staff notices, get a test.
Okay, great. All right, so we're going to end, and it sounds like we'll probably want to invite you back or something because this has just been super valuable. But in the interest of time, we need to finish. So just a reminder, in order to get your CME, your CE or Certificate of Attendance, please go to the website, complete the online evaluation form. And your comments are very important to the planning committee. So also, please write down the things you would be interested in discussing in future sessions. And tune in this coming Wednesday, we have a talk on COVID goals of care conversations. And we're going to have Dr. Takeshi Uemura and Dr. Eric Chin. Dr. Eric Chin is a colleague of Dr. Uemura, who is actually in Seattle, Washington, and having lots of these COVID conversations. So please join us on Wednesday. Thank you very much, everyone.
Thanks for having me and good luck.
Thank you so much. Appreciate it. And I hope you're on the mend and feeling better.